Have you ever wondered why there are so many different opinions in the field of temporomandibular disorders? Well, my name is Marcel Matos. I'm a dentist here in Brazil, as you can tell by my accent. I'm a TMD specialist. Here in Brazil there is a specialty recognized by Brazilian authorities called temporomandibular disorders and orofacial pain. And I'm here to review a 10 rule guideline published and released recently on internet by the Italian TMD study group. And this 10 rule was supposed to be a kind of gold standard and supposed to be used by dentists all over and for maybe for patients too, to use it as a reference. Pay attention to this review, because this kind of information that has been shared all over the place impacts people's life. Maybe yours if you are suffering from TMD, or if you are a dental professional looking for a continued education on the field of temporomandibular disorders, and may think that these kind of golden rules are golden. They are not. Take a few minutes, join me, and see by yourself why I'm talking about this. Temporomandibular disorders, the 10 rules published by the Italian study group as a guideline for every dentist managing TMD temporomandibular disorders around the world. And they share this all over internet as the golden rule of this field. But let's take a closer look and let's see if the 10 rules are actually scientific facts or just myths. This is the first rule of the guidelines. The temporomandibular disorders are musculoskeletal condition, not occlusal pathology. And there is this reference to the American Academy of Dental Research statement from 2010. If you take a closer look, you're going to see that the first part of the sentence is actually true. Temporomandibular disorders are musculoskeletal condition. But how about not occlusal pathology? Is that true? Let's take a look on the reference that they used as a support to that idea. If you follow the link, you're going to land in this page here from the International Association for Dental Research, and there is this text here, Charles Green publication from 2012. This publication was the guidelines based on those ADA statement of 2010. As you can see in this inner part of the paper, this is the exactly text, the exactly words, literally, that you can find in that link from the Italian group guidelines. But what is actually very interesting about this is that occlusion is not even mentioned in this paper. Not even mentioned. They're not stating that occlusion is not the problem. They are not even mentioning the word occlusion. So the other interesting thing is that this was published by Green, and Charles Green himself, in a previous paper published in the Journal of Orofacial Pain that is connected to the American Academy of Orofacial Pain, had to admit himself in a discussion of another dentist that the impact of occlusion in temporomandibular health is not zero. He recognized that, as you can see here. And then, being one of the biggest ambassadors of the biopsychosocial theory, he had also to admit that this is not always the case, as he stated. As you can see here, he stated, I agree that one or more of the factors in the multifactorial TMD equation may sometimes be structural, joint anatomy, disc integrity, muscular tolerance, as well as functional, occlusion relationship, parafunctional oral habits. Well, as you can see, if you go to that direction, you're going to be using measuring tools like biometrics. But let's talk about this later. By now, what is important is the Journal of American Dental Association policy statement about TMD do not exclude occlusion. Actually, it don't even mention occlusion. And besides that, the author of the paper himself had to admit that impact of occlusion in the TMD is not zero. So that first rule of the 10 rules guidelines of Daniele Manfredini is not true. Actually, when someone does something like that, put a reference to support a statement that actually do not state what is written, it not seems that this was done with good intention in mind. Actually, this is not good science. The second rule of the Italian study group of craniomandibular disorders is this one here that states that the size and symptoms is rarely attributable to a single etiological factor and mentions the multifactorial etiopathogenesis, and then use a paper from Klesser et al. 2017 to justify this affirmation. But when we check the reference, the Klesser paper, it's interesting because they do not deal with cause and consequence, nor have a study design to deal with that or to drive any conclusion. It's just a descriptional text talking about disorders classification and try to check the problems with the different, or at least some classification that we can find nowadays. What is really interesting in this paper is that if you go to the conclusion, you're going to see that they actually states that there is no clearly superior classification, considering the classification that they took in account. And they say, in particular, there is a strong need to improve the knowledge on pathophysiology of many of the orofacial pain conditions. That means they are trying to go to the same direction we already are, talking about TMD pathology at least for almost 20 years. And they're trying to go in that direction. And they say that these psychosocial classification basically cannot explain severity of symptoms or are not predictable. So the second rule is not valid because what it states is not supported by the paper in the reference. The following three rules are very interesting and very critical and must be evaluated in group. Let me read the third rule, the first of these three. TMD diagnosis is based on clinical assessment and history taking. And then there is the reference of Schiffman, 2014. But actually, what they try to say is TMD diagnosis is based only on clinical assessment. But we may say, okay, Marcelo, but they're not saying only. Yes, they're not saying only in this sentence here. They're not saying only in this sentence here. But take a look in the other two. The 4 rule is all about invalidated technology device such as electromyograph, and the number 5 is trying to make imaging less important. So without imaging and without biometrics, the diagnosis would be based on physical examination and history taking, and they try to use clinical assessment as equivalent expression for physical examination, but it is not. And you're gonna see that. First, let's take a closer look in this third rule with this reference to Schiffman. This reference is very interesting because it's supposed to say the same, that the clinical assessment and history takings is the only thing necessary to support the TMD diagnosis. But actually, this is what this paper states of this author, Mr. Schiffman. But in 2017, 2016 worked on the same subject, evaluating the diagnostic criteria for temporomandibular disorders. The same author, this is the protocol endorsed by Orofacial Pain Academy, the Academy for Facial Pain, to diagnose this TMD. And using this, evaluating the same protocol, the same author states this: the diagnosis criteria for temporomandibular interarticular disorder, with exception of the displaced disc without reduction with limited opening, can only be used for screening purpose due to inadequate criterion validity. Definitive diagnosis require MRI and TMJ computed tomography. Well, that's interesting because they used a 2 years old reference, 2014 to 2016. The same author wrote something completely different, the opposite. And this publication of Daniele Manfredini in his website is 2017. They could use the more updated reference, but no, he chose to use an older reference just to support this ridiculous idea. That's very, very interesting because it's just like the fake news. This is the fake science. But how about that clinical assessment? Clinical assessment is not the same as physical examination. It's not the same. Let's take a look on the definition of clinical assessment by Mosby's Medical Dictionary, 2009. It states that evaluation of physical condition is based on information gathered from physical and laboratory examination and the patient's medical history. That means when you put laboratory examinations here, you're talking about things that you do not get from the patient without technology. You need to understand that clinical assessment is more like this. This is the best definition of clinical diagnosis from Pedro Laentrauga, a Spanish physician, and he stated, clinical diagnosis is the sum of all diagnostic elements, not all of which can be obtained by the patient's bedside. That means lab tests, imaging, and biometrics, and whatever we have to get data from the patient to enhance our diagnosis capacity. What takes us to the rule number 4. None of the available technological devices, electromyograph, kinesiograph, postural platform, and the others, has diagnostic value. And here comes the reason for them. Because they do not correlate with symptoms. There is a reference, and then the best diagnostic instrument is our brain. With this last one, I agree. But it seems they are not using their own brain because they don't understand how to combine the data from technological device with the clinical reality. This is the paper, the reference for the 4th rule of the Italian study group. It was published in the Journal of Oral Rehabilitation, and it deals with electromyograph and kinesiograph recording in the diagnostic of myofascial pain. And here comes the first problem. Pain is a subjective symptom. And this technology is intended to measure things, especially function. Pain is not measurable. So how you compare these two? Besides, they took as a good standard the RDC protocol, which is not valid. This is the protocol for the TMD classification endorsed by the American Academy for Facial Pain that is not valid. So it was updated, it was replaced and updated in 2014 for the TMD, which has its own problem. Anyways, let's say this paper is correct for a while. It is not, but let's say it's correct for a while. The only thing that the 4 rule could state would be that this technology is not valid or has no value for the diagnosis of myofascial pain, not for the other TMD pathology conditions. Besides, the paper only deals with electromyograph and kinesiograph, and the 4 rule mentions postural platform and the other measurement tools. But if you apply the same technology, like the electromyograph, to measure function, it does has its role, because we are talking now about lesion and how lesion and all the pathology affects function. And now it is a valid tool, a valid instrumentation. It may not be for myofascial pain, because pain is subjective, but if you're talking about arthritis, osteoarthrosis, asymmetry, it is valid. The same goes for unilateral temporomandibular joint osteoarthritis. And again, it also has its value, its diagnostic values for children with and without temporomandibular disorder. One more, it also, the electromyograph has its value as a diagnostic tool for patients with tension type headaches that present some difference in masseter's activity. And so, if you go to the most important level of scientific evidence called meta-analysis, together with systematic review, we have this paper published in the European Journal of Dentistry, where it actually states that EMG is one of the biometric tests that occur in the modern evidence-based dentistry practice. In other words, they are completely wrong about the technology. The reference do not support the 4 rule. Besides, it's clear that they don't understand the difference between sign, symptom, and TMD itself. For example, the reason they said that the diagnostic technology, the technological device for diagnosis, has no value was because it do not correlate it with symptoms. So let's apply this to other technological devices, such as computed tomography. You can do a computed tomography, find the osteomyelitis, but that do not correlate with symptoms because the patient may be asymptomatic. So the computed tomography by the Italian group's logic has no diagnostic value because they do not correlate with symptoms. Does it make sense for you? One more, temporomandibular joint involvement in rheumatoid arthritis, where most of degenerative change occurs in asymptomatic individuals. So, taking account the logic of the guidelines, we would have to say that this imaging technique has no diagnostic value because they do not correlate. This degenerative change do not correlate with symptoms once the patients are asymptomatic. Could you believe in it? What is interesting is that in juvenile idiopathic arthritis and rheumatoid arthritis is very common the absence of symptom in the temporomandibular joint. So we would be using imaging technology to find the lesion, all the pathology. We could see, we could measure, but by the 4 rule, it wouldn't have any diagnostic value because it would not correlate with symptoms, because there are no symptoms in case like that, at least to 87% of the case. So the problem is they don't understand the nature of symptoms. For example, let's talk about fever. The mother puts the hands over the head of the kid and say, "Oh, looks like he has fever." The father touches the same place, the same spot, and say, No, I don't think so. Who has the reason? The one with a thermometer, the one who can measure the functional aspect of the problem. The functional aspect of the problem is the changing in temperature, and this can be measured. And this is not new. This is the father of the measured medicine. This is the guy that in the end of the Renaissance, almost 400 years ago, started to measure function. And this guy is the one who adapted the thermometer for the first time to check the temperature of a human being, and it actually could for the first time tells if a person has fever or not. And for almost 400 years later, we have people in dentistry trying not to measure things. I don't know how to call that in advance. It seems to me a primitive diagnostic without measurable technology. And it is very interesting that Charles Green himself, in that same paper, position paper, published in the Journal of American Dental Association, he states that patient's history, clinical examination, and when indicated, TMD radiology and the other imaging procedure, what is, in fact, technology. But when it is indicated when there is orthopedic problem or signs that there is a orthopedic problem. And we know that there is no occlusal stability with a damaged joint in active situation. Besides, it does state that what is used in medicine for neurology, rheumatology, and other orthopedics, all the technology, laboratory tests, and the other tools that are used can and should be used when indicated. And again, when is indicated to use this in dentistry. I think it's the other way. If you don't use, you are neglecting the patient's rights to have a better diagnosis. So even the original paper turns to be a horrible reference to support any of the statements of these 10 rules, because actually the paper works against the 10 rules. So the 4th rule is a complete disservice to science. Complete disservice to science. Let's take into account that the reason they use to say the technological device has no diagnostic value is that it does not correlate with symptoms. But I showed that even bone infection may not correlate to symptom, and you want gonna rely only imaging to check it. As I stated before, they're not using their own brain. And let's go for the rule number 5, imaging techniques. And they refer specifically for MRI and computed tomography. They say that it is supposed to be used only in selected cases and or a second step diagnostic assessment in individuals who do not respond to common conservative treatment. It's very interesting because let's think. Hippocrates said that diagnosis precedes treatment. So you start a treatment, the patient do not respond, and after that you go for the diagnosis tool. Again, it sounds very primitive. Maybe in a era before Hippocrates, because you cannot do that. Maybe your treatment approach may have worsened the problem, and if you don't have a previous MRI, for example, and you do a MRI once the patient does not respond as you expect, all the damage that you see in that MRI maybe was created by the dentist himself who was trying to do something. So this is a complete out of logic, and this is history. Check this reference. What you can and cannot see in TMJ imaging. An overview related to the RGC TMD diagnostic system. And again, the same protocol that is not valid, that was replaced by the DC TMD protocol because it had too many problems in its classification system. And they are comparing imaging to that protocol. And they say this is not required for diagnosis. Rely only on the protocol that's not valid. Interesting. Let's check this RGC TMD validation study. This protocol was tested for sensitivity and specificity, and it was considered by their own standards not valid for the majority of the diagnostic classification. Actually, this validation study was done by the same authors who created the protocol in first instance. It's not valid for almost everything. Only one item, the muscle palpation for myofascial pain with range of motion limitation. This was the only part of the classification that was valid. For all the rest, disc displacement, etc., it was not valid. And it was this not valid protocol that in the previous paper we were seeing was being used as a golden standard to compare the biometrics. I really don't understand that. And if we talk about the DC-TMD, the upgrade version of the dinosaur RGC TMD, the problem persisted in this author that we talked about him earlier made two publications basically talking about the same subject but changing his position from the first paper to the second one published in 2016, showing that and stating that the TMJ needed MRI and combined tomography for the majority of the diagnosis because the protocol had a failure. So all this effort to lower the value of imaging in the diagnosis process is a complete fraud. Imaging techniques is necessary and required for proper diagnosis. And this is said by the same authors who created the protocol that is not valid in the first instance. And then we have the rule number 16D, treatment is seldom a occlusal therapy, and use as a reference Charles Green paper from 2001. This paper is very interesting. It was published in the Journal of Orofacial Pain 2001, and it's all about the etiology of temporomandibular disorder, implication for treatment. What is really interesting is this part here. Let's read together. Reviewing the history of etiological thinking in the field of temporomandibular disorder, I conclude from this review that not only are the old mechanistic etiologic concepts incorrect, but also that the two of the most popular current concepts, biopsychosocial and multifactorial, are seriously flawed. Therefore, what we really have at the individual level TMD patient is nearly always an idiopathic situation. We simply do not know enough, or cannot measure enough, or cannot precisely determine why each patient has TMD. Charles Green. Isn't it interesting? He states that cannot measure enough. and that the problem is always idiopathic. Idiopathic from the Greek means a pathology from the patient itself. Pathic, the pathos, disease, and idios, patient. Maybe he is correct when he states that they don't know enough. Yes, you don't know enough. The seventh rule is that the TMD treatment is often provided in the form of symptoms management, with a focus on psychosocial correlates of pain. And there is a reference again. Let's see how it. This is a paper published in the Murphy Seminars journal, Murphy Seminars in Orthodontics, talking about predisposing and precipitating factors in temporomandibular disorder. There was a patient with an anterior open bite that was treated with orthodontics to close the bite. 1 year later, as can be seen in the legend down here, 1 year later, the patient had again a relapse, had again an open bite. There was a relapse. And then the dentist working the case decided to combine new orthodontics to orthodontic surgery. And 2 months, only 2 months later, there was again a relapse. So, in a case like this, without symptoms, no pain, according to that last rule, seventh rule, I think, you should not treat the case because there is no pain. And if you treat like this, working on the occlusion while the joint is creating the occlusion stability. The name of this, Charles Green, I already stated. They do not understand, they do not know enough. And how about this? A condyle resorption, a huge resorption, that gave to the patient this open bite, a very impressive open bite that took only 6 months to develop. And how about the juvenile idiopathic arthritis, the silent killer of pediatric temporomandibular joint? Half of the patients usually are asymptomatic. So we are not going to treat this patient because the treatment should be based on pain and psychological variables. So there is no pain, no treatment. And then we end up with a patient unstable occlusion, relapse, and facial deformities. Grade 7 rule. Rule number 8. Symptoms management can be usually achieved by means of conservative and reversible approaches: counseling, physiotherapy, cognitive behavioral treatment, physical therapy, oral appliance, without predetermined occlusal designs. I think this was written here just to bother people who works with orthotic, like neuromuscular dentists. But okay, let's see the reference. It's a paper from Manfredin, Temporomandibular Disorder Assessment, Medical Legal Consideration in the Evidence-Based Era. It has nothing to do with the statement. It does not support this statement. It's talking about legal aspects. And it states that pain is the guiding symptom in the phases of decision-making and treatment planning. But let me tell what is all about. What is this all about? If you actually follow these rules, you start treatment without imaging, without diagnosis, without knowing what is going wrong with function, I'm sure you're gonna end up with a very complicated medical legal problem, for sure. But to be more interesting, the same author, as you can see here, in this paper from 2006, Temporomandibular joint disorders in patients with different facial morphology, in a systematic review, he actually states that most of class 2 profiles, hyperdivergent, are very associated with TMJ disc displacement and degenerative disorders. Isn't it interesting? The own author understands that these TMJ problems is connected to these facial deformities, but he says that without symptom, especially pain, you should not treat it. But the same patient is the patient that is looking for orofacial surgery to correct the class 2 because they think this class 2 is only a dental or facial problem. And behind it, there is a unstable joint that's going to give an unstable occlusion with a relapse, just like we saw in that paper. I think they're not their own brain. So the rule number 8 is not valid. And how about irreversible occlusal treatments? Orthodontics, prosthodontics, occlusal adjustment, or applies to search for ideal inter-arch relationship are not recommended and should not be used to prevent or treat TMD. Yes, I agree with them, because they say they don't know much. They do not know in an individual level which patient has TMD. So that TMD is all about pain. So I agree with them. But it's not the case if we are talking about TMJ pathology. Check this reference. The reference is this: orthodontics is temporomandibular disorder neutral, from the same author, and he's King. This is very interesting because this paper deals with orthodontics only, and the 9 rule is talking about prosthodontics, orthodontics, orthotics, and puts this reference that don't give a minimum support to that statement. A minimum support. I actually agree to be careful with not reversible treatments. But the problem is they don't know what patient to treat, because they do not know what each patient has TMD or not, because they don't have imaging, and they are using a protocol called RDC TMD or DC TMD that is simply not valid for today's standards. But let's talk about some splints in orthotic now. The statement said that it should not look for a specific jaw relationship, the inter-arch relationship. But this is the opposite of this kind of studies shows. In this kind of studies, use imaging to check it. As you can see, condylar remodeling accompanying splint therapy, a cone beam computed tomography study of patients with temporomandibular joint disc displacement. And they found that the condyle start to recover once the patient is wearing orthotics in a specific position. In this case, orthotic intended to repositioning the mandible forward, even doing the way the author did, is a specific inter-arch position. And how about this one? Looking for a specific inter-arch position and checking it with MRI. And they found that specific relationships are better than the others. So the 9 rule is more fake reference, fake ideas, and so fake science. Finally, the rule number 10. Patients with chronic pain require a multimodal approach managed by an expert in orofacial pain with focus on phenomena of central sensitization and maladaptive pain experience. Evidence-based dentistry and professional deontology requires clinicians to consider the patient in his/her pain and not the dentist with his/her unuseful technicism and dogmatism as the fulcrum of the diagnostic and treatment program. I actually agree with this part here. It's very interesting because to accomplish that, one must first throw all the 9 rules away. Why? Because they are all full of dogmatism and unuseful technicism. And it is not evidence-based dentistry. Having more fake reference and reference that do not support these statements than any other guidelines I have ever seen. The idea of having the diagnosis based on signs and symptoms is more than 400 years old, and this is not the respect that the patient with their pain experience expect from us. To respect them, we need to give them the best treatment possible, and this requires the best diagnosis possible. And to have the best diagnosis, we need to use the proper tools. We need to use imaging, biometrics, patient history, and so on. And therefore, we're going to know enough, we're going to measure enough, and we're going to know why a given patient has TMD in the individual level. Only taking this direction, we're going to have that enough to deal with patient central sensitization and all the other phenomena that pain patient experienced. So in order to this 10th rule to be true, one must throw all this guideline away. My name is Marcelo Matos, and I hope you have enjoyed it.